All right. My pleasure to introduce our next speaker, Dr. Stephen George, who is the Medical Director of Surgical Services and Chief of Spine Surgery at Nicholas Children's Hospital in Miami. And he'll be speaking about high-grade ischemic spondylolisthesis.
Good morning. And again, great to be here. Thank you to the chairs for having me back. It's always a pleasure to travel this far to come to this course, actually. As I said, I'm here from Miami. This was previously Miami Children's, now Nicholas Children's. And I'm going to be talking a little bit about the treatment of high-grade spondies. I call this part one because one of our colleagues will be also talking about this tomorrow, Dr. McClendon. Let's see. Here's the disclosures, nothing relevant to this talk. And as an overview, we'll talk a little bit about the definitions of spondylolisthesis and spondylolysis, progression, history, pathogenesis. Diagnostic evaluation, we'll go into a little bit about that, some on the classification, and some surgical management, and more closely towards my preferred technique. So we'll start just with a case. This is a simple case. You guys probably all see this in the office. A 15-year-old comes in with a history of worsening back pain, bilateral lower extremity pain. You know, you've treated it conservatively with rest, corset, PT, so on and so forth, but still continues to get worse. Now she's unable to play her sport, which is soccer, and starting to become uncomfortable with just performing normal ADLs. The exam shows basically normal sagittal balance. She has a palpable step off in the midline, really tight hamstrings bilaterally. She's got back and leg pain with flexion and extension. And we just get a standing radiograph. She's got a little bit of a limb length discrepancy, which she's had for a bit. Small scoli here, but then when we look at the lateral radiograph, we see that it's got a high-grade spondy here. And when we look closely, we see that this is in the setting of also some transitional anatomy. This, you could call this, I guess, a sacralized L6 or a lumbarized S1, who knows. But again, we'll talk a little bit more about, this sort of aberrant anatomy, how common it is, and, how do you safely treat this condition in this setting. We talked about the transitional anatomy. This is probably a grade 3. We have a slip angle of 25 or 43 degrees, depending on how you measure it. And by definition, again, spondylolysis is just that defect in the pars interarticularis without displacement of the vertebral body. It's actually relatively common, 6 to 8% in the general population. But when you look at athletes, especially those with extension activity in their sport, you see the prevalence is more along the lines of 35 to 40%. Now, spondylolisthesis, that includes the slippage of one vertebra relative to the adjacent lower vertebra. And when we look at this area of the spine, obviously there's a lot of forces at work at the lumbosacral junction, including some axial loading, forward flexion, and some truncal rotation. And for this to be maintained, you really have to have an intact posterior osteoligamentous tension band and also an intact disc. When we start to see this listhesis, it really represents the failure of this tension band. And it's most common at the 5-1 level. Clinical presentation often starts with some back pain, sometimes radiating to the buttocks and posterior thigh. You might see some numbness and tingling, especially weakness in the L5 dermatome. On exam, again, you really need to do a very close neuro exam, but you can see this Phelan-Dixon gait sign, which you see this crouched gait and these tight hamstrings, and on radiograph you see this common slippage of 5 on 1 here. And when we get down to it, we'll talk a little bit more about it, but sort of understanding this idea of this slip angle and why that's so important. You often see this associated mild scoliosis in this area here, but also understanding some of the pelvic parameters. That we go a little bit further into that when we talk about some of the classification systems, which try to help us understand, what should be the goal in this type of condition. Advanced imaging is sort of standard of care in a lot of these patients. When we start to have neurologic symptoms, we really need to identify stenosis, and it also helps us to identify the chronicity of some of these injuries. An MRI is really great for that. But when it comes to surgical planning, we start to look more at CAT scans as to gain the understanding of, well, how are we going to fix this? What do we have to work with? And one of the things, though, that has started to become more popular, and we have at our institution, and if you guys should look further into, is this idea of a synthetic CT. It's basically an MRI sequence that allows you to generate this CT-like sequence, and this is starting to become more and more common in our field. Has anybody here ever used this or have that modality at their institution that they know of? Okay. I don't see many hands, but the fact of the matter is you probably do, because it's a sequence that's very common on just on magnets that GE or Phillips magnets that are around, and it doesn't actually add much time to the scan, but what it actually allows you to do is create an image just like this. And so at the top here, we have a true CT scan. And then down below here, this is the synthetic CT. And what you're able to do, honestly, is you can, to probably 1 millimeter of accuracy, you can basically recreate this CT image. And that allows you to basically scan this, one scan for the patient, 0 radiation, and really impressive ability to get 3D models of this bony anatomy. When we start thinking about classifications in the pediatric population, we're really talking more about dysplastic and isthmic spondies. But we still use this Myerding classification just to help us understand the degree of slip from 1 to 4, and then 5 being spondyloptosis. We won't really get too much into the treatment of spondyloptosis so much. I think that's sort of beyond the scope of this talk, but we will mention a few techniques. The Spinal Deformity Study Group and Mac Tiang from St. Justine in Montreal really go into a lot of detail and granular detail about pelvic parameters and understanding the different types of spondies, whether it's a high or low grade. Yes, but they talk more about the balance of the spine and whether the spine is unbalanced or balanced in the setting of this high-grade spondee. They find that this is important because it gives some context to what the goals of treatment really should be, whether this is a deformity that needs to be reduced, or whether it's a deformity where you just need to address the slip angle. And I'd have to sit down with a cup of coffee and 30 or 40 more minutes to really go through all of this entire classification system. But it does really break down some of the differences in these patients and tries to address what the needs of that individual patient is in a surgery to correct a deformity like this. Now, overall, when we look at high and low grade spondies, there's a lot of similarities in the early stages. In low grade, this is usually a condition that's mostly treated non-operatively with activity modification, usually avoidance of certain sports and activities with hyperextension for 3 to 6 months, physical therapy, NSAIDs plus or minus steroids depending on some of the symptoms. Now, indications for surgery in the low-grade group really is limited to sort of a persistent or progressive pain, progressive neurologic changes, and progressive slip, especially in the musculoskeletally immature patient. And also the inability to return to desired activities, and this is often the case in very high-level athletes who have these low-grade slips that we can fix. And so far as high grade, again, you start with the non-op treatment, and you can stay in that category if they can maintain, good quality of life, no neurologic symptoms, and the imaging remains unchanged. However, when we talk about indications for surgery, there's an absolute indication, for cauda equina, for example, but relative for, the condition that's unresponsive to treatment in the setting of progressive pain, lower extremity radicular pain and weakness, and then slip progression. And again, this is going to be most common in the younger population with a lot of growth remaining. When we think about surgical treatment, the goal's pretty standard: achieve a solid fusion, attain optimal global sagittal balance, to correct the slip angle. And again, that is sort of a local deformity that usually has a big impact on the global sagittal balance. And then to preserve or improve neurologic function. So historically, when we look at this, back in the 80s, there was a lot going on how to treat this condition. One of the early treatments really just consisted of traction and cast reduction. Unfortunately, they didn't have great success with that. It was fraught with motor deficits and prolonged treatments. And then, still in the 80s, the idea of just posterior distraction was a common treatment. And that looked at basically using the upper lumbar spine and the sacrum to create a distractive force to help correct this deformity. Unfortunately, it really it had moderate success. The improvement of the slippage was about 5%, but usually they found worsening of the slip angle. And you would imagine that because just using posterior distraction is more of a kyphogenic technique in the first place. So that didn't work out so well. But still in the 80s, you had DeWalt and Bradford who were working on staged posterior instrumentation along with an anterior interbody fusion. They actually had some success with this. However, they did see quite a bit of neurologic deficits with this procedure and some loss of reduction during that. About 20% of patients had loss of reduction. At that same time, as you guys may be familiar with, Bowman and Cook were working on, posterior decompression and posterior lateral fusion with the transsacral L5 interbody graft, the Bowman technique. And I'd be remiss not to talk about this, but this is out of the scope of this talk. But in their first, description of this technique, they used 2 patients, and the patients actually had great symptomatic relief, no neurodeficits and no pseudos at 2 years. And since that time, there have been many modifications to the procedure, but again, beyond the scope of this talk. So Roy Camille, in the late 80s, started using pedicle fixation with a slotted plate. And that actually was sort of the start of what we currently see as a posterior-based approach to this. He was able to improve the slip percentage by about 55%. Unfortunately, about 10% of these patients suffered from neurologic injury. Then Steffi, later in the 80s, started using a pliff to help with reduction. And he also added in some longitudinal traction pedicle screws to help with that. That technique actually was published on 41 patients and with relative success. However, he did have some permanent foot drops, a couple transient foot drops, and what they call the lumbar stretch palsy. And one of the big things in this procedure was the reduction was, again, based on distraction. And as a result, potentially developed a lot of the complications that you see here. The one thing that is important to note about this technique was that no pseudos were actually reported. And again, this was using the pliff. So what's the theoretical advantage to reduction? Theoretically, you improve the local alignment. It improves global balance, but it decreases the risk of pseudoarthrosis because you now have, more surface area to actually for anterior fusion. And when we look at even recent studies looking retrospectively at reduction versus non-reduction, that also does bear out with 5.5% rate of pseudos in patients who had reduction versus 17.8% in those who had in situ fusion. And it's this theory that Edward and Bradford really had when they started using their technique in the mid-90s, which was based on basically a gradual instrumented reduction, but a posterior-only arthrodesis. So what their thought was basically an anatomic reduction negated the unfavorable biomechanics of a high-grade slip. And if they were able to achieve that, then there was no need for an interbody graft. And in their series, they actually reported pretty good results. They had 25 patients with one pseudo and one neurologic incident. However, when you sort of look at, other people using that technique, there was a multi-center group that they looked at, and they had a 13% failure rate and a 6% neurologic injury. And then even later, Dr. Hugh and colleagues in the later 90s reported much, much poorer results using this technique with increased pseudos and neuroimpairment instrument failure using that same technique. So when we talk about neurologic changes, one of the big things we look at is this L5 nerve root and how vulnerable it is in this condition. Back in the mid-90s, a cadaveric study looked at this and looked at the course of the L5 nerve root. And it was interesting because obviously it being very vulnerable in high-grade spondies, the question is, when reducing, what do you do to avoid that? Well, one of the main takeaways from this was that 25% of the nerve strain occurs in the first half of reduction, and 71% actually occurs in the second half of reduction. So the idea is that it's more protective if you're more modest about your correction because, you gain a lot by going from getting that first 50% with lower risk, but it's the last bit that actually causes, that makes it less safe. And another thing that they found was that increasing lordosis in that area actually creates a more relaxed path for the nerve. And so this kind of gives sort of credence to the idea of restoration of this lordosis or fixing this, this segmental lumbosacral kyphosis could be protective of the nerve as well. So then you fast forward a little bit, and this is with Jürgen Harms, and he talks about this wide decompression and distraction with a pedicle screw and anterior support. And this is getting much, much closer to, again, what we think of as a posterior-only approach of today. He looked at 112 patients, found that he improved the slippage by 92% and improved slip angle by 92.5%. He did show that, about 4% of the patients had some neurodeficits. And then other people using these same techniques actually found similar success. So it seemed as though this was a very reproducible technique. And then later, my mentor and once partner, Harry Schuffelbarger, took sort of that technique and added a few key differences. And one of the big things he added to that technique was the compressive force after distraction. He in a paper in 2005 talks about having a wider L5 decompression via a gill laminectomy and going past the sacral ala and releasing the alar transverse ligament. It uses distraction on the sacrum and with hooks on the lumbar spine, and all the while actually using stimulus-evoked EMGs to monitoring the L5 nerve root. Once Once the decompression is done, adding in the anterior inner body and then compressing over the L5-S1 is done, plus or minus a dome osteotomy. And in his report, it was only on 18 patients, but had no pseudos, no instrumentation failures. The one failure he did talk about is very interesting, and that is he had a 5-1 fusion, but the deformity was actually recurred through the 1-2 segment. And if you see here, here's the high-grade spondy, here's the post-op, and you see this recreation of the deformity, but it's actually coming through a rudimentary disc at 2-1. So that kind of gives some understanding of all the things you really have to pay attention to. And sometimes it's just not the high-grade spondy, but it's actually other local anatomy that you must also be aware of. So some key concepts: restoration of the slip angle to help restore local alignment and allowing for better global sagittal balance, safe reduction, anterior inner body to allow the deformity to correct over a fulcrum. So when you actually put that anterior inner body, when you start to compress across it, it actually brings that lever arm or that fulcrum more posterior, and again, that's going to improve the health of the L5 root, and also improve the slip angle as well. Assessing the anatomy, how reducible the deformity is, and the bone quality and the screw purchase that you have are really critical in deciding what levels you're actually going to need to fuse. Sometimes we go up to L4 because of poor fixation at L5, or go down to the pelvis because of poor fixation in the sacrum. So just understanding that these are sort of the things that you need to be aware of when even determining the levels. So again, I won't belabor the point, but I think this is a technique that I commonly use. Here we have wide exposure, L4 to S1 with a gill laminectomy. And at this point, we use, direct nerve stimulation. Usually normal is going to be below 2 milliamperes. Sometimes we find it higher, and then through the procedure, as we do the decompression, this will get better and better, which is always a great sign. When we instrument from 4 down to the sacrum, we always leave the joint at 4-5. We preserve that just in case we can remove that screw after distraction, so we don't always have to go to start at L4. Okay, and then once we actually put in we do the decompression, we put in the rods, we actually start with a little distraction, we do the discectomy. Sometimes, if needed, we'll do the dome osteotomy. We'll continue to recheck the nerve at that point. We'll put the inner body in the disc space, and then we'll put in a temporary rod. And usually that rod starts off by being kyphotic, and then we'll continue to change it out with compression. And actually at the end, we'll get a lordotic rod. And at the end, we'll have a normal lordotic rod. So really, what has changed? I think that in considering these kind of deformities, it's a complex lumbopelvic anatomy, dysplastic pedicles, aberrant sacral anatomy, whether it's a transitional anatomy or a dome. I think there's great opportunity in the utilization of the CT guided navigation, giving us sort of more predictability of placement fixation in the inner body, and more precise cuts or osteotomies for the sacrum, and the ability to really intraoperatively plan where we're going to place our screws and how we can sort of make that harmonious with the upper and lower instrumentation. And this is just, again, some scans we have from, a patient we did a little while ago, showing you your ability to not only pull or find a trajectory, but also plan if you need to add more than one screw, iliac screw. We can do all of that. And that actually can be translated into our patient here, again, with transitional anatomy, sort of understanding where we can place fixation. So that it's harmonious and it's not in some of these smaller patients, so it's not prominent. So here we have her at 6 months in this patient. But again, we did 4 to the pelvis. Again, I think that with the navigation, this becomes very predictable and becomes a fairly easy day because even in this situation of transitional anatomy, you can sort of plan out intraoperatively where you want to put your fixation. You can get these small L5 pedicles on one shot, and if needed, go to L4. So in conclusion, there's definitely more than one way to successfully treat a high-grade spine. We'll learn more about that tomorrow. I prefer this technique. I think it's the safety of the posterior approach is important to me, with avoidance of the plexuses up front. The ability to monitor the L5 nerve health throughout the procedure is important. Able to achieve excellent anterior column fusion from the back. Safely improve the deformity, and the ability to leverage navigation to predictably have results in these challenging cases. Thank you.
George, thank you very much for a really nice overview of a difficult topic. Tell us a little bit about the direct nerve stim and how you've utilized that. And are you doing that before or after you see alerts? Or
so no, I do it from the very beginning. And a lot of times with these, even after doing the gill laminectomy, you'll see both S1 and L5 just under incredible tension. And we'll stim it there as our baseline. And sometimes that could be 5, 6, 7 milliamperes. And so we use that as the baseline. And as we continue to go through decompression and reduction, the idea is that we want it to only go in one direction. So it's almost like, a neuromonitoring alert if it starts to go in the opposite direction. If it stays the same, that's fine. But usually once you start, getting up over the ala and you start with that distraction a little bit and reduction, you see that number fall. So, knock on wood, I think it's been a huge improvement in our ability to predict what the post-op exam is going to be like.
I asked you about the MRI to CT. How many people have done that in their practice? I had never actually heard about it before today. So, yeah, definitely. I think for our pediatric patients where we don't want to get CTs, that's hugely powerful. Do you need to have a 3 Tesla magnet, or what are the?
No, it's actually, you don't need a 3 Tesla magnet. It's actually more of a software thing. It's a sequence that they have to do. And one of the sequences is a 0TE sequence, which I can talk to you about. But there's other sequences that don't add any time. So at most, it's going to add 5 to 7 minutes. And to be honest, it's such an important sequence in these types of patients. And you talk about even your congenital patients as well. You're getting an MRI anyway. This is a huge add-on. You can build your 3D models off of this as well. I think that there's a lot of promise, and even on the front of enabling tech to be able to use this as sort of for guidance as well. That really hasn't been done yet, but I think that that's probably the next way, where things are going.
Thanks for the great talk. One of the things about these patients, sometimes they can be fairly asymptomatic. And obviously this wasn't the focus of the talk, but how do you address that with maybe some of these young athletes, maybe teenagers, and, they're doing fine, but they have a pretty high grade slip there? Yeah.
A lot of counseling. And I have probably close to six to 8 patients in my practice right now in that exact situation where they're a high-grade slip, and we just watch them, because to say you're going to take them out of sports to do these sorts of things, well, you give them the option. You say, hey, we're going to watch this. If they're skeletally immature, then it's a little bit more nerve-wracking because you think it's only a matter of time. But in the older patients, it's not. They could go on for a while, but as long as they have that, close follow-up and they know that this is something that could change, but it doesn't, I don't rush them. If I see that there's a, radiographic progression, then I'd probably push them a little more. But if it's stable, I don't too much. Yeah.
All right.